I treat everything in terms of general orthopedics, but my practice is kind of tailors itself as you get older, I guess, and I'm getting older. So 2/3 of what I do now is arthritis. 2/3 of what I do is joint replacement, and I work on the shoulder, the hip, and the knee. And then 1/3 of what I do is kind of sports and a little bit of neck fusion, carpal tunnel, trigger fingers, ulnar nerve releases, and things like that general orthopedic doctors do. So this is very informal. You can use this as your free orthopedic consult, especially when we're done, and ask me anything about anything that's hurting. I've given the talk on the hip here, I've given the talk on the shoulder here, and then today I'm going to cover knee. And knee pain is actually the most common thing. Knee arthritis is the most common joint to be seen for arthritis, followed by the hip, followed by the shoulder. My practice is a little skewed because of that anterior hip, and people were doing really well, and I got a niche for doing hip replacements. But I still do almost as many knee replacements, and my dad was known as the knee guy, so I still get a lot of knees. And so I'm going to take this talk kind of like I did with the shoulder talk. I just go through all the different things that can cause knee pain, and we can focus on whatever you want, and then in particular knee replacement and knee arthritis. So I'll sit down so I can run this thing. So here are the causes, the most common being arthritis. Chondromalacia is a fancy word for early arthritis, where the cartilage starts to get soft and wear down. Meniscal tears, which are little shock-absorbing discs of cartilage between the bones. Ligament tears, which is the anterior cruciate ligament, or the ACL, the posterior cruciate ligament, or the PCL, the MCL, which is the medial collateral ligament, and the LCL, which is the lateral collateral ligament, and then tendonitis, which is this irritation of the tendons around the knee. This arthritis is very common. Right now, there's about 700,000 knee replacements per year in the U.S., and that's expected to dramatically increase. Some people say like 666% in the next decade because of the baby boomers aging. And it's more than that. And we don't know why, but it is more than that. It's younger patients I'm doing knee replacements in 30-year-olds now. It's amazing, and I don't know if it's the obesity that's really doing it, because I see young people with it too. So we don't really understand what is causing the cartilage to wear off on people's bones. It's not, it's not sports. It's not working on concrete floors. It does have some genetic link to it. If everybody in your family had a knee replacement, you're getting one too. There is a genetic component, but this is pretty much the demographics of knee arthritis now. This is what a healthy cartilage looks like. If you look at like the end of a chicken bone, it's white, it's firm, it's smooth surface. This is hyaline cartilage that coats the end of the bones. And when we talk about arthritis, we're talking about this wearing off. It's getting red, irritated, and it's painful. The covering of the bones is the periosteum, which is underneath of the cartilage, and when that gets exposed, that's where all the nerve endings are, so that's why it hurts. This is what a typical x-ray looks like of a person with bad knee arthritis. The bones are rubbing together, there's no space between the joint's shifted over a little bit, it's collapsed, it's crooked, and you get all these little bone spurs. The body cannot make anything except bone and liver. So in an attempt, the theory is, in an attempt to sort of stabilize the knee or help this thing out, it makes extra bone. And that, I think it's God's clue on an x-ray that there's arthritis in the knee to us, because otherwise there's no functional benefit to bone spurs. So there's a couple different types of arthritis. There's rheumatoid arthritis, psoriatic arthritis, and osteoarthritis. So the inflammatory arthritides are rheumatoid, which is the most common. That's where the lining of that's an autoimmune disease where the lining of the knee is attacking the joint. So that's what's digesting the cartilage and causing all the inflammation and all the problems. And people with psoriasis, it's also an inflammatory type of arthritis. And usually that's managed medically by the primary care doctors and the rheumatologist with medications. Osteoarthritis is what we call run-of-the-mill arthritis or wear and tear arthritis, and everybody, if they lived long enough, would get osteoarthritis. It's just the nature of the beast. We're around long enough, it's our tire wearing out, and that's the most common form. There's here are the treatment options that we go through, and we go from the least invasive to the most invasive on this list. So the first thing, when somebody presents with arthritis, and of course it depends on how bad it is, and not just how bad the x-ray looks, but how bad their symptoms are. We start with weight loss. Your weight doesn't cause arthritis, but it makes it hurt worse. You know, if you're already worn down and you have an extra 50 pounds of pressure with every single step, it matters, it hurts. Also, having weak muscles for some reason causes you to be more symptomatic with your knee pain. I have power lifters in my practice with these big, huge muscles, and even though they have terrible arthritis, they tolerate it pretty well. It's pretty funny. They come in and they're like, "Doc, what's this bump?" I'm like, "That's a huge bone spur." But they're not complaining of pain. So it's pretty unbelievable how good it is to have strong muscles. But it becomes a catch-22 for the patient, because you can't really build your muscles up if you have a painful arthritic knee, because it hurts to do the exercises. So sometimes we do get kind of stuck there. Omega-3 fish oils do seem to have some benefit. I think they're probably the best supplement out there in general for people. But there's no hard and fast science that does anything to rebuild cartilage or anything dramatic. I think it has anti-inflammatory properties which help. Glucosamine and chondroitin sulfate as well. It's a mild anti-inflammatory, so it may offer a little bit of benefit, but it's really not worth the expense. Most of it's metabolized by the liver. It doesn't help you regrow cartilage. It was a huge moneymaker for the nutraceuticals. Non-steroidal anti-inflammatories has been the mainstay. That's the naproxen, the Motrin, the Celebrex, the Mobic, all those type of medications that decrease inflammation. They do help with the symptoms, but they're hard on your kidneys, they're hard on your guts, and it's not something you want to take long term. Tylenol was the #1 drug by the American Academy of Rheumatology for osteoarthritic pain. Tylenol is also the #1 cause of liver failure in this country, so you can't eat a million of them either. Then we get to injections. The first injection that's been around forever is cortisone. Cortisone, we found, weakens tissue over time. So it's a great anti-inflammatory. Somebody comes in and they're swollen and they're miserable, they're going to get a cortisone shot. But it's not something you want to get a lot of, because it'll actually precipitate the disease getting worse, because it softens and weakens the cartilage over time. Same thing with skin. You see people that put a lot of steroidal creams on their skin. They get weak. The skin gets weak. It loses elasticity. It gets wrinkly. Prednisone is one of the best and worst drugs we have. Oftentimes doctors were mixing lidocaine or marking anesthetics with the cortisone injection. In the last 2 years, there's been a lot of literature in the orthopedic literature that the anesthetics also have a toxic effect to the cartilage. I stopped doing it. So people probably aren't as happy leaving my office as they are leaving other doctors' offices, but when I give you a cortisone shot, unless it's for a diagnostic reason, I don't put any local anesthetic in there, because I don't want to hurt your cartilage anymore. Viscose supplements have been around a long time. That's hyaluronic acid. So that's the normal lubricant that's in the joints. It's made by the lining of the joints. And by supplementing a joint that's arthritic with that, basically putting more oil in a rusty hinge, seems to help. We don't know exactly how or why it works on a biochemical level, but it is safe. It doesn't weaken your cartilage over time. It is just a natural lubricant. It's usually made from chicken combs, is how they get it. There's a couple recombinant forms as well. There's tons of companies that make this. Synvisc is the biggest one. They've been around the longest, and they're the company that has come out with a one-shot injection. Hyaluronic was the first. That was a series of 5 injections. The myth about the viscose supplements, depending on what doctor you go, all comes down to money, of course. If it's a private practice, oftentimes they buy these cheap from Canada and they mark up the drug so that they can make a profit on it. But because I'm at Mercy and that doesn't matter, and when you find doctors where it doesn't matter, that you can get the Synvisc injection in a one shot instead of having to come back to 3, and it's just as efficacious without any increased risk in side effects or pain.